Good evening everyone, this is Dr. Chaitanya Oak again. Welcome to my channel Critical Care Basics. In this channel we are running ECG tutorials and this is the 42nd ECG tutorial. In last ECG tutorial we talked about the etiology of AV blocks in general and in detail about first degree AV block. In this lecture we will be talking about second degree AV block, Mobitz type 1. So in second degree AV block we have Mobitz type 1, which is also called as Wenkebach, and Mobitz type 2. So in this lecture we will discuss about Mobitz type 1 or Wenkebach AV block. So let's start. Before we talk about the Wenkebach block, let's discuss about the definition. So what is the definition of second degree AV block? As we all know, when some of the atrial impulses are not conducted to the ventricle, then that becomes a second degree AV block. That is, the P wave is not followed by the QRS complex. In Mobitz type 1 or Wenkebach block, there is progressive prolongation of the PR interval, and PR interval goes on prolonging with each beat, and finally there is a P wave which is not conducted to the ventricles. So there is no QRS that follows the P wave. So that is a non-conducted P wave, but before that for several beats you have progressive prolongation of the PR interval. In Mobitz 2 there is PR interval is constant and then suddenly a P wave fails to conduct to the ventricles. High degree AV block is that block in which two or more consecutive P waves fail to get conducted to the ventricles, but at the same time it is not complete AV block, that is not third degree AV block. There is no AV dissociation because some P waves continue to get conducted to the ventricles. So this is the first degree AV block. In last lecture we had at length discussion about first degree AV block. How is first degree AV block defined? A prolongation of PR interval. So it starts from the beginning of P wave to the beginning of Q wave. So this is more than 5 small squares or more than 200 milliseconds. So this becomes first degree AV block. In second degree AV block, we have Mobitz type 1, which is called as Wenkebach. Here the PR interval, which was initially shorter, gets progressively prolonged till there is a loss of conduction. That is, the P wave does not get conducted to the ventricle. So PR interval goes on prolonging and then one P wave doesn't get conducted to the ventricles. So this is Wenkebach or Mobitz type 1 block. In Mobitz type 2, the PR interval remains constant. The PR interval remains constant. And there is suddenly one P wave is not getting conducted to the ventricles. So this is Mobitz type 2, second degree AV block. In the fourth ECG from the top, we have something called as 2:1 AV block. So this is PQRST, then this P is not getting conducted, again PQRST, this P is not getting conducted. In such type of ECG, it is difficult to distinguish whether it is Mobitz type 1 or Mobitz type 2. So in such cases, you may require a long strip or some maneuvers to decide which block it is. And lastly, third degree AV block, where the P waves are coming at regular intervals, but they are not getting conducted to the ventricles. So there is regular P activity, the atrial rate is about 75, and there is regular ventricular activity, QRS complexes, but there is no interconnection between the ventricular activity and the atrial activity. Ventricular rate is about 30 per minute and the atrial rate is about 75 per minute. And lastly, the lowest ECG shows high degree AV block. This P is getting conducted to the ventricle, and then this second, third, two P waves are not getting conducted, and again this P wave is getting conducted. So such ECG is called high degree AV block. So let's discuss about Mobitz type 1 or Wenkebach block. This usually occurs within the AV node. So the prolongation or the PR prolongation, this block occurs usually within the AV node, but may also reflect a delay elsewhere, that is in the bundle of His as well. This can be seen in antegrade AV conduction when this impulse is coming from the SA node. This can also be seen in retrograde conduction when the impulse is arising from the ventricle and getting conducted to the atria. It can also be seen as an exit block in ectopic or parasystolic pacemaker. So parasystolic means a sinus node is beating and a separate pacemaker is beating in parallel. So we have already discussed in our previous lectures about parasystole. In parasystole also you may get exit this Wenkebach block. What are the factors which are required for this Wenkebaching or this sequence? You require a constant input, so you have to have SN node which continues to fire an atrial impulse as a regular pace, regular intervals, and then an area of increasing conduction delay and a non-conducted P wave. So the conduction delay gradually increases and then there is a non-conducted P wave. The PR interval is shortest in the first conducted P wave. This PR interval is the shortest. However, the largest absolute increase in the delay following the first P wave. So the largest delay after this non-conducted P wave, the largest delay occurs in the first P wave only, right? So there is the largest delay here, then there is incremental small amount of delays which goes on increasing. Because the delay goes on increasing, you have a clustering of RR. So output to decreasing RR interval usually decreases with each conducted P wave. So because there is less and less incremental delay, this RR interval tends to decrease. Still there is a loss of conduction. So usually in Wenkebaching there is a group beating. The classic Wenkebach pattern occurs usually with a ratio of 3:2 or 4:3. Like 3 beats, the PR interval goes on increase and then there is a loss of conduction, again 3 beats and loss of conduction. This gives rise to a clustering of beats. You can see there is a clustering of beats here and then there is a loss of conduction, then again clustering of beats and then loss of conduction. The pause shorter than 2 input cycles, that RR intervals involving the non-conducted P wave is less than the sum RR interval of any 2 previous. So this is a non-conducted P wave. This RR interval is shorter than any of the 2 RR intervals. That this is shorter than this interval. So how does it present? Typically it is benign. Mobitz type 1 block or Wenkebach block is usually benign. Only rarely it produces symptoms. So Mobitz type 1 second degree AV block most often involves the AV node and rarely progresses to complete AV block. So usually most of the times the problem is within the AV node. The delay is within the AV node. So it is not something which commonly occurs below the AV node in the bundle of His. So there is less chance of degrading into the complete heart block. As we have already discussed the causes of AV blocks, so you have to undergo thorough evaluation. Any patient presenting with Wenkebach block, you have to evaluate the history, the medications, and we'll come to it in the next slide. So find out whether the patient has history of heart disease, either congenital or acquired. Whether patient underwent any cardiac procedures or any change in medications, or rarely the patient may not have a primary cardiac disease but a systemic heart disease which may involve the heart, like amyloidosis or sarcoidosis. A patient may be living in the endemic area with Lyme disease. In that case, find out whether the patient has a exposure, outdoor exposure or history of a tick bite. If Mobitz type 1 occurs in the setting of acute MI, then the patient will require treatment for acute MI as well as for AV block, Mobitz type 1 AV block. And if the patient does not have a cardiac disease or any other systemic disease which may involve the heart, last but not the least, check the drugs, whether the patient is taking some drugs which alter the AV conduction, especially beta blockers, non-dihydropyridine, calcium channel blockers like verapamil or diltiazem. Digoxin can cause any type of block, and select antiarrhythmic drugs. Like we just discussed, most patients do not have any symptoms. In the setting of acute MI or myocarditis, if the patient develops Mobitz type 1 AV block, then there could be decrease in ventricular output, cardiac output, causing symptoms of syncope or fainting or whatever. In healthy patient, if the patient has bradycardia and on the top of it, if the patient has Mobitz type 1 AV block, then patient may have symptoms of hypoperfusion. So usually patient present with bradycardia or patient may have a normal sinus rate or rhythm. Other than the presence of irregular pulse, there are few specific findings. If the patient has bradycardia and develops Mobitz type 1 block, then the patient may be diaphoretic or pale due to decreased cardiac output. Patient with underlying heart failure that is exacerbated by Mobitz type 1 block may develop signs of congestive cardiac failure. So how do you differentiate between Mobitz type 1 block and the other blocks? For first degree AV block, the only thing that you see in the ECG is a prolonged PR interval. So all the P waves are conducted to the ventricles. Only the PR interval is prolonged more than 200 milliseconds. Then that is first degree AV block. Simple. In Mobitz type 2, all the PR intervals of all the beats are constant. But suddenly one P wave is non-conducted to the ventricles. So that is Mobitz type 2. Patient with third degree AV block have atrial activity, that is P wave, which are regular, and ventricular activity, that is QRS complex, which may also be regular, but they are independent. The atrial and ventricular activity is running independent of each other. So that is complete heart block. If the PR interval of a conducted beat is very long, so if the beat is conducted, but the PR interval is very long, for example more than 300 milliseconds, and the QRS complex is narrow, then it is more likely that the ECG that we are looking at may be having a Mobitz type 1 AV block, because here the pathology seems to be in AV node, because PR is very long and the QRS duration is normal. Now if there is doubt, the maximum doubt occurs when there is 2:1 conduction. Every alternate beat is not conducted to the ventricle. PQRST, then next P is not conducted, again PQRST, next P is not conducted. So if this is the situation, then you may be confused whether it is a Mobitz type 1 or Mobitz type 2 block. In that case, you could use several of the maneuvers like atropine. Atropine is a vagolytic. If you give about 0.5 milligram atropine IV, then atropine will increase the AV conduction. So the non-conducted P wave will reduce. It will reduce the frequency of non-conducted P waves. So it will actually improve the Mobitz type 1 AV block. If this does not happen, a lack of response to atropine is consistent with Mobitz type 2 AV block. This is not confirmatory, but it is more likely that the problem is below the level of the AV node. So more likely to be Mobitz type 2 AV block. Likewise, another procedure that you can do, maneuver you can do, is carotid sinus massage. Carotid sinus massage stimulates the vagus nerve, increases the vagal tone. So you expect that Mobitz type 1 block will worsen. So in case if there is a contradiction, that is there is apparent improvement in AV conduction with the slowing of sinus node impulses due to cardiac massage, then it is more likely that this is Mobitz type 2 AV block. So this can help in differentiating Mobitz type 1 and type 2. Electrophysiology study is very rarely required for Mobitz type 1 AV block. So usually it is not performed, and with simple ECG you can diagnose. EPS is indicated in those patients with syncope or pre-syncope with 2:1 AV block. So when there is 2:1 AV block and the patient is symptomatic, syncope or pre-syncope, and you are not very sure whether this is type 1 or type 2 Mobitz block, then sometimes you may require EPS. And what do you see normally in EPS? When EPS is performed in such patient, there is typically a progressively longer AH interval. A means AV node, H means bundle of phase. So the bundle of phase interval goes on increasing, while H to V, bundle of phase to ventricle interval, remains constant until final beat of the series, in which there is atrial electrogram with no subsequent ventricular electrogram. So duration will get prolonged, and then suddenly there will be atrial electrogram but no ventricular electrogram. Less commonly in Mobitz type 1, the problem is below the level of the AV node. In that case, in this instance, there will be usually two potential, H and H prime, due to the slowing of conduction, with the H prime interval prolonging, and then suddenly there is, in one bit, there is subsequent loss of QRS complexes. So how to diagnose? If the patient has irregular impulses and you see that some of the P waves are not conducted to the ventricles, so this is looking like a second degree AV block. In 90% of cases, diagnosis is simple. In simple ECG, you will see that there is subsequent prolongation of PR intervals with subsequent beats, and then there is loss of conduction. So you can diagnose Mobitz type 1 or Wenkebaching in on surface ECG. If the patient has 2:1 block and it is difficult to tell whether this is type 1 or type 2 Mobitz block, then get a long ECG strip and look for some evidence of 3:2 or 4:3 conduction. So if you see Wenkebaching in that type of conduction, then the diagnosis is clear, this is Mobitz type 1. If there is no clear-cut distinction, then you can try carotid sinus massage or IV atropine, and only rarely, if you still cannot diagnose and the patient is symptomatic, then you may require EPS. So how do we manage Mobitz type 1 or Wenkebach's AV block? If the patient has no symptoms, then just evaluate for reversible causes. If the patient has symptoms, see whether the patient is unstable or stable. If the patient is stable, just evaluate for reversible causes. If the patient is unstable, give atropine. After atropine, if the patient becomes stable, again, only thing you require is evaluation for the reversible causes. If the patient continues to be unstable, even after atropine, then going for transcutaneous pacing. And then if the patient remains stable, then look for the reversible causes. If the patient remains unstable, then if the patient has low blood pressure, start dopamine infusion. If the patient is in heart failure, start dobutamine infusion. And if the BP is normal and the patient does not heart failure, but the patient still unstable, in all three of the conditions, if the patient does not improve with these interventions, then you require transvenous pacing. And once the patient is stabilized, then see for the reversible causes. Then in algorithm 2, evaluate for the reversible causes. If there are no symptoms and no reversible causes, naturally the patient doesn't require any treatment. If there is no reversible causes but the patient is symptomatic, then he would be a candidate for permanent pacemaker. If you find some reversible cause, for example, the patient has taken a beta blocker or a calcium channel blocker, recently changed, or the patient had hyperkalemia, so treat appropriately and observe. If the patient improves, the AV block resolves, no additional treatment is required. But the patient still has Mobitz type 1 AV block and the patient is symptomatic, then he is a candidate for permanent pacemaker. So what type of pacemaker would you prefer in a patient who's having Mobitz type 1 AV block, or for that matter any AV block? So first you have to find out is it chronic atrial tachycardia and reversal to sinus rhythm is not anticipated. If the reversal to sinus rhythm is not anticipated, then whether the patient desires AV synchrony. So AV synchrony is ideally preferable in all patients, because otherwise the patient may land up in pacemaker syndrome. So if the patient is very old and patient has very little physical activity, then you may not go in for AV synchrony. Then in such patients, find out whether the patient requires rate response. So such patient usually will not require rate response as well. So you can simply go in for the ventricular pacemaker. This is the most cheaper. If the patient is young, then he wants rate response, then you may go in for rate responsive ventricular pacemaker. If the patient desires AV synchrony, which is more desirable if the patient has financial readiness for that, then see whether the patient requires ventricular response or not. If the patient is an old patient, doesn't require ventricular response, then single lead atrial sensing ventricular pacemaker could do. If the patient desires atrial pacing and desires for rate response, then rate responsive dual chamber pacemaker. If the patient does not desire for rate response, then dual chamber pacemaker alone. If the patient has chronic atrial tachycardia and reversal to sinus rhythm is anticipated, then just find out whether the patient has desires for rate response. If yes, then rate responsive ventricular pacemaker. If no, then simple ventricular pacemaker. So that is in nutshell about which pacemaker to use in AV block. Thanks a lot. This was a short lecture on Mobitz type 1 or Wenkebach AV block. In the next lecture, we'll discuss about Mobitz type 2 AV block. If you are liking these videos, please subscribe, share and like these videos. Thank you so much.